I'm honored to be here in this conference to present a case presentation, which is related to the talk that we had before. So I will start immediately. Our patient is a 40-year-old male who presented to the renal transplant clinic seeking renal transplantation. He is married, he has 3 offspring, and he has no special habits of medical importance. He has end-stage renal disease that was discovered accidentally 3 years ago. The etiology of his renal failure was unknown. He had bilateral small-sized kidneys at the time of presentation. His family history was not significant for any hereditary or autoimmune kidney disease, and his past history was not significant except for occasional non-steroidal intake for headache. The patient has started hemodialysis 3 years ago, 3 times a week through a left radiocephalic AV fistula, which was thrombosed 1 year later, and a second right brachiocephalic AV fistula was functioning until the time of his presentation to our clinic. He has no history of previous blood transfusions. He is currently on amlodipine 10 milligrams OD for his hypertension and is well controlled, and is using recombinant erythropoietin for his anemia. His donor is his wife, a 35-year-old female. All her deliveries were normal with no complications, and the last one was 5 years ago. She was using an IUD as contraception. She had no significant family history or past history. So this is our pre-transplant evaluation. The patient, the recipient, has undergone autoimmune profile that included anticardiolipin and lupus anticoagulant antibodies that were all negative. For the radiological examination, things looked quite well. The ascending urography for the recipient showed no signs of vesico-ureteric reflux. And for the immunological profiling, the HLA typing showed a mismatch of 4/6, and the flow cytometric cross-match was negative for both T and B cells, and a virtual cross-match, the panel-reactive antibodies by Luminex, showed no detectable anti-HLA1 or 2 antibodies in the recipient. So this was considered a low immunological risk transplant, and the patient was started in day -1 on mycophenolate mofetil, 1 gram BID, and cyclosporin 125 milligram BID. Patient's dry weight was 75 kilograms, and basiliximab was given 20 milligrams pre-op. The operation was uneventful. Donor's left nephrectomy was done. Ischemia time was 38 minutes approximately, and 500 milligrams of methylprednisolone was given at declamping. There was immediate diuresis, and the patient was vitally stable throughout. His blood pressure was 150/80. So post-op, we had a fairly stable recovery. On day 1, creatinine declined to 2.7. And the cyclosporin level was increased to 150 milligrams and 125 milligrams at night. Clexane was started at 40 units. On day 2, creatinine further declined to 2.3, and cyclosporin level was increased to 150 milligrams BID. On day 3, creatinine further increased to 2.7. Platelets declined to 65. LDH level increased to 2,000. And urine output significantly decreased to 50 milli to 100 milli per hour. So our differential diagnosis at this case was acute rejection. Any patient with an increase in serum creatinine and oliguria 2 days post-renal transplant, acute B and T cell rejection should be considered. However, in the case that we have also a high LDH and low platelets, so calcineurin-induced thrombotic microangiopathy was also considered as a differential diagnosis. For this patient, we do not know what is his original kidney disease, and that's why we might have circulating factor H antibodies that had activated a recurrence of thrombotic microangiopathy, so this was also considered in our differential diagnosis. Acute tubular necrosis, of course, is considered either cyclosporin-induced or due to any surgical complications. And surgical complications and vascular complications also were considered in this patient in the setting of oliguria and thrombocytopenia very early post-transplant. So we looked at the drain output. The drain output was 150 milli at day 1 and down to 50 milli the next day. So there was no significant bleeding, and we had a stable hemoglobin throughout. The ultrasound was done, showed no collection. Resistivity index was 0.8, and there was no evidence of renal artery stenosis. Fragmented RBCs were absent and haptoglobin was normal. So what was our next step? Well, the first step we took was to stop cyclosporin, and the patient started on Solumedrol 500 milligrams. That was given 3 successive days. ATG was given at day 4 at a dose of 1.5 milli per kg. And by day 5, we had a serum creatinine. There was no improvement. We had a serum creatinine of 3.9. Patient was still oliguric, and platelets were further declining to 51. So we started plasma exchange. We exchanged 40 milli per kilogram with albumin. And this was continued until day 7. Of course, we did not take a graft biopsy because the patient was still thrombocytopenic at this time, but there was, by day 7, after the second plasma exchange, there was an increase in his platelet level and starting to improve in his urine output. So in all 5 doses of ATG were given, a plasma exchange was initiated and patient received 5 sessions with exchange of 40 milli per kg of plasma with albumin, and a flow cytometric cross-match was still negative for T and B cells, and as I said, the graft biopsy was delayed due to thrombocytopenia. So by day 9, we had a platelet level of 120, which was considered safe to start to take a graft biopsy. And this is his biopsy result. We had 15 glomeruli, none were obsolescent, and they showed marked glomerulitis and infiltration by mononuclear cells. Tubules showed diffuse moderate injury. The interstitium was within normal. We had peritubular capillaries that showed moderate capillaritis and infiltration by mononuclear cells. And we had endotheliitis in arterioles, and there were no C4D present in peritubular capillaries. So the diagnosis was acute T-cell mediated rejection, accompanied by acute active antibody-mediated rejection. We had a mixed rejection in this patient. The results of pan-reactive antibodies done post-transplant were still negative for HLA class 1 and class 2 antibodies. So here we were considering the entity of the presence of non-HLA antibodies. This is a low immunological risk transplant by all means, and the patient was received induction by a non-T-cell depleting antibody basiliximab, but still we had a picture of mixed rejection. So for the entity of non-HLA antibodies, they can develop due to the presence of either self-antigens or epitopes against self-antigens, and these antigens are present on the endothelium, and they only manifest when there is ischemia reperfusion injury that will express these epitopes, and also they might be present due to the presence of donor epitopes on polymorphic antigen that are present in the donor or not in the recipient. And there was a study that was done that showed that even HLA identical siblings can have acute rejection or rejection that can happen due to non-HLA antibodies. So an example for these antibodies was a major histocompatibility complex. It was the first one that was discovered, the MICA. There was also anti-endothelial antibodies that can activate complement, but also there are other which are non-complement fixing, which explains the negative cross-match by flow cytometry in these patients. Also, angiotensin 1 receptor antibodies were incriminated in acute rejection that happens post-transplant with resistant hypertension, and even at this point, it is refractory to steroid use. So what happened to our patient? We considered slow tapering of his steroids, continuing ATG for 7 days, optimizing the cyclosporin level or switching to a more potent agent such as tacrolimus, continuing plasma IG, considering IVIG, and considering rituximab. So what happened for our patient is that he was switched to tacrolimus and started at 2 milligrams BID. Steroids were tapered slowly, and his creatinine started to improve with improvement in his urine output. And by day 15, we had a creatinine of 1.4 and FK level reached 5.7. And we were aiming on reaching a level of 8 or 9. So the patient was discharged from the hospital after receiving 6 more plasma exchange sessions. He did not receive IVIG. His serum creatinine was around 1.3, and his tacrolimus level was 10 on 4 milligrams BID of tacrolimus. During his follow-up in the outpatient clinic, his creatinine was creeping until it reached 1.8. The FK trough level was 9.8, which is very adequate. So we considered starting to give this patient rituximab, and he received 2 doses, 500 milligrams, 2 weeks apart, and was discharged with a serum creatinine of 1.2. So